and I really never spent a lot of time thinking about all the fundamental differences between them. So this was really interesting for me. I think I learned a lot in preparing for this. Oh boy, now I'm seeing everybody, that's weird. So I want to make this more of a discussion, and since I can't see your faces, you're gonna just have to sort of like chime in and interrupt me, and so don't feel bad about that. So I think the goal for me for this topic is really to sort of understand the complementary role that observational studies can play in learning health systems in comparison sort of always to the gold standard of a randomized controlled trial. And so here's our learning objectives. We're going to sort of think through some of the differences between observational studies and RCTs, and specifically about how observational studies can provide valuable input, especially in a learning health system model, either in place of or in complementary addition to randomized controlled trial data. And then at the end, we'll talk just briefly about some analytic methods that are pertinent to observational studies, particularly if you're trying to figure out the best way to feel certain about potential causality, which is a weakness of observational studies. And I'm not a methodologist. Some of these methods I had not heard of before, so don't ask me any hard questions. Maybe other people on the call will be able to answer them, but some of them I was like, whoa, and I never heard this before, and I've been doing this a long time. Okay, so really briefly, what is an observational study? And I took this definition from the Institute for Work and Health. And it's basically studies where researchers observe something, so a risk factor or effect of a diagnostic test or treatment or some kind of intervention without trying to change who's in the group. So you just kind of let nature take its course and you're looking to see what happened. And the key thing here, of course, is that the data is not randomized. So patients are generally observed for outcomes, oftentimes in some other setting like a clinical setting. And of course, observational studies can be retrospective, where you take data that's already been collected and you look back and see, oh, what happened over time. Or they can be prospective, where you really are maybe having a little bit more of a role in planning what kinds of variables or data pieces you want to capture moving forward. So maybe you're actually making a change to a clinical data collection system to be able to capture data that you want. So can anybody think of some examples of types of studies that would be observational studies? I'm going to try to go back to your faces now. Anyone want to chime in? There's at least 3 you should be able to think of.
I mean, there's like the retrospective chart review that I think many people are familiar with, and that would be observational.
Yeah, good. Anything else? I'll give you a hint. Case control is one of them.
Cohort study.
Cohort study, yeah. Those are kind of some of the 3. And then I would say a comparative effectiveness, I would call trial in sort of parentheses or quotation marks, is another one, because a lot of times we have, multiple types of treatment or interventions going on clinically, and there can be data that's collected to be able to at least try to make some inferences about the effectiveness of one type of intervention compared to another. And there are other ones, we're going to go into those more later. So I think this is really the crux of the whole talk, is really diving deeper into the key differences between the two. So of course, observational studies are not randomized, whereas a randomized controlled trial is. And generally what this means is that with an observational study, it's much more difficult to assign causality to the effect of an intervention, because there's things that you might not have controlled for adequately because you're not randomizing. Generally, observational studies are a lot lower in cost, often because the data is already being collected for some other reason, and so your role is really just to find the data and then analyze it. Whereas, of course, with an RCT, where you want to have a really highly controlled environment, that costs money to make sure all of the checks and balances are in place and you're adhering to the strict rigor of the protocol. So what this means is that the internal validity for RCTs are generally higher because it's more controlled. but the external or real world validity is often higher for observational studies. And that's because observational studies allow for more of the natural variation that might happen in terms of just regular clinical care with regard to your patient population, or how an intervention or medication or whatever is actually delivered, and compliance and things like that. And so it can give you a lot more data on how you would expect something to happen in real life as opposed to in the setting of a highly controlled clinical trial. As we talked about, the data source is often already available in observational studies, like the retrospective chart review that somebody mentioned before. We talked about population heterogeneity and then sample size. So this can be also a really important thing. And later on in the talk, we're going to try to come up with some case examples. I've got one where sample size played a particularly important role. But because RCTs are so expensive, they're often on a smaller scale than something that you might think of like a whole system's clinical data that you can analyze, which is much larger. And then the clinical context. So, most RCTs happen in academic centers or pseudo-academic centers, places that are set up for research, whereas observational studies are a lot more varied, and that gets back to this idea of them being real world. And then the other thing that I had never really thought of, but it makes a lot of sense, is that RCTs often have a much shorter duration of data collection because you're trying to control everything about the trial and the participants, and that's harder to do on a longer term, whereas observational studies often allow you longer times to collect data, which can be really beneficial in certain situations. Okay, so this is another interactive component of this talk. I don't usually do talks like this, but I'm finding that like with webinars and web-based talks, especially ones where I can't see people's faces, I often feel like I'm just talking to my computer. So we're going to try to make this interactive. So can people think of some of the advantages in terms of real-world assessments of observational studies compared to RCTs? And I kind of alluded to some already, but like what are maybe some more specific things? Why an observational study might be better suited for answering a clinical question. Oh, we got a helper. Hi.
It may be more applicable to the patient population that you're taking care of, rather than the very homogeneous population that the trial was intended for, with very strict inclusion and exclusion criteria that you can't use when you're actually at the bedside.
That is a great example. Yeah. So people in trials might not really reflect your patient population. People think of other ones?
The providers may not actually, in an RCT, may not actually reflect the providers that would actually be delivering the care in a real world setting. And so you're actually using actual providers in actual healthcare settings as opposed to a lab setting.
Competing priorities for time and for lots of other things to think about. That's a really good thought as well. Anybody else?
You may learn about barriers to implementation that wouldn't have arisen in a controlled trial.
Awesome, that is a perfect one, right? So the whole field of implementation science, which really I think overlaps a lot with learning health systems. A lot of that you don't get in an RCT, especially ones that are more highly controlled. I mean, maybe in a more pragmatic style RCT, you could collect that, but in a sort of really classical, highly controlled RCT, you won't. And that's huge for learning health system, right? You might have a great intervention, but if nobody can use it, then how good is it? All right, let's see what else we came up with here on the list. So we sort of talked about this a little bit in terms of the doctors, but what happens if you only partially implement an intervention, right? So not everybody adheres to the protocol, and that's often what happens. People aren't compliant with our recommendations. So that's another area. We talked about the second one. Another one that you guys didn't come up with, but is very true, is how you can collect data when an RCT wouldn't actually be considered ethical. And there are definitely situations we can all think of where you just can't do an RCT. And so an observational study is really the only way to be able to potentially answer some questions about what's a better clinical pathway than another. Then we talked about earlier the ability of observational studies to have a larger sample size, and that can be really helpful when it comes to assessing subgroups. So, we can think about all the data that's coming out right now on COVID-19 and how there's signals that certain subgroups with certain clinical manifestations or certain racial or ethnic backgrounds do more poorly than others. And so, you might not be able to see that in an RCT that doesn't have enough power to look at all the different subgroups that you want. And that also builds into the following bullet, which is identifying rare side effects, because sometimes you need really high numbers to be able to see things that are really rare. And the other one I never thought of, but it's so true, is that there's reporting bias potentially with an RCT, right? Because you're trying to adhere to a very stringent protocol, and maybe that's minimized because you're collecting data for other purposes, right? You're just providing clinical care, and this is what really happens, and you're not thinking about when you're coding for something or doing something, how it's going to reflect on a study. And as you mentioned before, it really helps to identify the role of context in an intervention's effectiveness, which has a huge impact on learning health systems. All right, so there's also some easier logistics. So data are often already available, especially in electronic format. So that can be a huge deal in terms of the timeliness of being able to do something. It's usually cheaper for the amount of data that you get out of it. And of course, that's always balanced by, is it the right data, right? Sometimes it's worth the money to pay more to get the data that you actually want, as opposed to some kind of maybe, electronic medical record system data that isn't exactly what you need. Can usually be faster because the data is already collected. And it may be more feasible to include patients with only partial data or partial exposure, as opposed to in an RCT where you might have to eliminate those people. And then we talked about the longer period for data collection. So those are some of the advantages in terms of logistics and just sort of like the scientific application of observational studies compared to RCTs. But I think, when I was reading through the articles that I sent you, and one of them was actually a series of 4 articles that I read through all of them, what I came to a conclusion with at the end was that there's really a role for both of these, and one will probably never take the place of the other, but it's helpful, I think, to sometimes really critically think about when are they complementary and when is one needed as opposed to another type. So what are some disadvantages of observational studies compared to RCTs?
So there may be some variables or outcomes that you're not going to be able to measure due to the limitation of your data source.
Yeah, so confounding, unmeasured confounding, for sure.
It's harder to establish causality.
Yeah, and why is that? Like, what's the actual underlying reason for that? I mean, we always say that, but I never really thought about it before.
Well, I guess because, you're sort of noting that 2 things are correlated, but without manipulating one variable. I guess you don't really know if that variable is the reason why something else changed. Exactly. And I think also you don't know. You'd have to know that the groups who were getting 2 different interventions, for example, were similar at baseline, and that there wasn't something about those particular patients that resulted in them getting one intervention versus another.
Exactly, right. The whole point of an RCT is you're trying to control for all of the measured and unmeasured confounders, and hopefully the only difference between your 2 groups is the one thing that you're manipulating, and that's the reason that you can assume causality, which, it makes total sense, but I don't know, just one of those things that I had not really sat down and thought through in a lot of ways. And I do a lot of pragmatic trials where things aren't as clean as a classic RCT, and so it really made me think about, the conclusions that I've made or are making based on these pragmatic trials. And we do our best to try to control between groups, but in a pragmatic trial, you don't have that strict adherence to a protocol, and so there are probably differences between the groups. And so really thinking critically about what does that mean for your interpretation of your outcomes. So I think we talked about this, like the first 2 biases, right, about confounding, about factors that can't be statisticalized away. I made up a verb there, or unknown factors. And then, of course, potentially misclassified or missing data, right? With an observational study, you often are just left with whatever data you have. And especially if you're doing retrospective, you might be missing some things that are actually critical, like maybe you don't actually have the race of the people for 30% of your sample, and how does that factor into your conclusions? And you know, there are ways to try to account for that, but they're all imperfect. And then the limits to causality, which is the way that they talk about it in these articles, is that you can't easily define the counterfactual. So in an RCT, you're basically making the assumption that group A and group B are identical except for the one thing that you're changing. And so one is the counterfactual to the other. But in an observational study, you can't make that assumption. And so you actually don't really know what the counterfactual is, because you don't know what all of the variables that are different between the groups are. And then another thing that I hadn't really thought about, but makes total sense, and is something that comes up in PedsNet relatively frequently, is these ethical considerations about consent and privacy, right? So are people actually fully aware and in agreement that you're going to use their observational data that got collected, you know, as part of their clinical care, for example, to make conclusions about a treatment effect or something else? You know, that's probably not what people were thinking of when they signed their consent form, but that is what happens sometimes in observational data studies. And so sometimes there can be questions about that. And then, you know, this issue of validity, right? So this gets back to the limits of causality. So people call RCTs the gold standard, and so many scientists, I think, assume that, you know, scientific validity in terms of assigning causality is much more rigorous and easily attributable in an RCT than in an observational study. But what I thought was interesting about these articles is that there was some degree of argument about maybe this actually isn't the case. And one of the authors, I don't know if it was in the article I assigned to you guys or the other ones, but one of the authors actually tried to make an argument that with the advent and availability of big data, you can actually potentially do away with a lot of RCTs, because you have powerful enough data available in other forms that are equally as valid in terms of assigning causality. I'm not sure I am completely on board with that, but I thought it was an interesting argument to make in these articles. Okay, so let's think a little bit about what observational studies roles might be in learning health systems. One of them was brought up already, right? What are the barriers or the facilitators to actually implementing an intervention that was maybe found in an RCT to be efficacious? What are some other ways in which an observational study might be useful when thinking about a learning health system?
There's a role for description of current state of, you know, both practices that are going on right now as people are delivering the care. Yeah,
that's a good one. Like, how far away are you from the ideal, or what you might think of is the ideal? Anything else?
It's a more like flexible way to be able to embed research into clinical care. So, you know, you have an observation and it's easy to implement it in this way rather than, say, a more rigid RCT type design.
Yeah, so more like, you're thinking more like a QI kind of thing?
Yeah, so either that, or just if you are trying to sort of learn from the work that you do, you can embed it within your system more effectively.
Oh, I see. So rather than trying something new, you're just trying to take what you're already doing and learn from that, right? Why do you need to create something new when you're already doing stuff that you can learn from?
Right.
Yeah, that makes sense. Any other thoughts?
I think you can go faster too. I mean, you know, like in the sense that if you have this existing observational data and as part of the learning health system, to say the whole point is to be able to constantly reevaluate what you have. So you have observations going on, and that's probably just what two teacher was saying, but it's a sense of speed.
Yeah, exactly. I mean, yeah, you're right. The whole problem with RCTs is they take a long time. At first I thought you were saying I should go faster with my talk, and I'm like, well, we're already going to be really short on time, but now I get it. Yeah, totally. I think that's a huge thing. Observational studies can go faster, and you can feed back the data. And I mean, one of the things that I think is particularly pertinent is that it's an observational study for your environment, right? So it's directly applicable to how your system is working rather than some other type of maybe more idealized system that doesn't really reflect how your system works. And so there's sort of a direct line of evidence into practice. Let's see what else there was. So again, understanding intervention's effect on specific populations. Maybe you work in an area where the population is totally different than what was in an RCT showing that something was really helpful for a particular disease state. And so you need to know, does it really work in your group? Let's see this. Oh, and then understanding an intervention's effects based on historical influences. So I think this gets a little bit to what Chitra was saying is like, you know, maybe you have intervened something in your hospital, but then there's some external thing that's going on, some policy at your state level. And so that might be important for other states as they're considering adopting a policy, and there's probably some kind of synergy or interface between maybe what that policy is suggesting, like ACA would be a great one, and an interventions effect. And then the other one is that you can start to generate hypotheses, right? So it doesn't always have to go RCT into observational study, right? Like you take a intervention and then you try to implement it and see what happens. You can also go the other way around, right? So observational studies, although sometimes they can't maybe assess causality, they can certainly bring up a lot of hypotheses and maybe help you to really hone in or optimize an RCT and make it more pertinent to the actual question that needs to be answered. So sometimes doing an observational study in preparation for an RCT can really help you either narrow the patient population or the type of intervention that you might want to be doing, or other aspects of your RCT. Sample size is another one, your anticipated effect size, so that you can make your RCT better and more relevant. Okay, so there are in these series of articles, they talked about using RCT principles to design better observational studies. And there's something called the Bradford-Hill criteria. I don't know who Bradford or Hill were, but presumably somebody that's a lot smarter than I am. And they talked about the example of cigarettes as being a risk factor for lung cancer. Well, there's never been a randomized controlled trial for that, right? You tell half the people to smoke and half the people not to smoke, and you know, see who gets more lung cancer. But it's pretty well established that cigarettes are a risk factor for lung cancer. So how do we know that? How is it that we've been able to make those causality conclusions without doing the quote unquote gold standard of an RCT? And I don't think this was probably set out at the beginning when people were doing this work, but in retrospect, when they look back and said, well, what was it about this particular issue of cigarettes and lung cancer that allowed us to make these conclusions? And is there some kind of generally applicable universal criteria that we can apply to observational studies that maybe make it more likely that you could create or assume causality between an exposure and an outcome? So here's what they came up with. The first is the strength of the association. So, right, obviously the stronger there is an association that's at least assessed in an observational study, that you could maybe think that there would be more likely an actual real signal there. It's not just some statistical aberration or something that you've controlled away and other things, and all of a sudden there's this association that actually is untrue. Consistency of this association across studies. So, right, in lung cancer and cigarettes, there was multiple studies in multiple different populations and multiple different types of ways that showed this very consistent association between cigarettes and lung cancer. And so from that, you can start to conclude, well, maybe, you know, the fact that these are consistent, maybe that means something. Also, this idea of dose responsiveness. Now, this would not necessarily work for every intervention, right? Some interventions reach a threshold, or, you know, you only get once, like you only get open heart surgery one time, hopefully. So there won't be dose responsiveness in those types of interventions. But in this case, you know, they were able to show consistently that more cigarettes lead to a higher risk for lung cancer. And so that also helps, I think, drive this idea that there's a cause and effect going on here. really importantly is that the intervention precedes the outcome. So lung cancer had a lot of longitudinal studies that were in that field, looking at people over time and the incidence of lung cancer, you know, in populations and factoring in at what time in that person's life did they start smoking, and they were able to show consistently that, you know, lung cancer went up after somebody started smoking. And then biologic plausibility. So these were studies that were done in animal models showing that, like, hey, there's a biologic reason why cigarette smoke could be carcinogenic, and we can understand some of the molecular pathways. And then finally, specificity. So when they're doing some of these other observational studies, they were able to show through a variety of different study types and different types of statistical analyses that the effect of on lung cancer seemed to be really specifically related to the cigarette exposure as opposed to other things. And of course, that can be one of the real difficulties with observational studies, is a lot of times your exposure variable travels along with a lot of other variables, and it can be hard to sort out what is the exact variable that's the cause. You know, so cigarette smoking might be also associated with being poor, and then poor nutrition and increased stress. And so which of those things are the things that actually are the thing that's causing the lung cancer? So it's really not any one of these things, but really sort of as many that you can check off on the list as possible that would strengthen your idea that there's a conclusion to be made between an exposure and an outcome in an observational study design. Okay, and then there's also some thought to be behind how you select your data sources to minimize the bias that is part of all observational studies. And I think this is where as you're planning your own work, I think this list of questions is actually really helpful. I know, you know, I mentor a lot of people that are trying to do observational studies, and I know I'm going to be using this list in the future to sort of ask them to think through these different questions to help understand the likelihood that their study that they're planning is going to actually be able to answer the question that they're interested in. So the first one is about the granularity of the data. So this is a reason why often like administrative databases are not very helpful for answering some of our clinical questions, is because the data aren't sufficiently granular, right? You might know days of medication, but not the actual dose, or you might know days of hospitalization, but not the number of hours, and not the timing of when you transition from, you know, the ED to the floor to the ICU, for example. So really understanding your data and how much level of detail you can get in the variables that you're interested in with regard to exposure variables and outcomes. And, you know, in an ideal study, you're going to have sufficient granularity for both the exposure and for the outcome. That doesn't happen very often, but it can happen. And, you know, some of the larger databases and that include clinical data often can have enough granularity for both of the exposure and the outcome variables. And then sort of related to that, but somewhat different, is are there adequate data to be able to allow for inclusion or exclusion, right? So maybe you have great data on your exposure and your outcomes, but you don't have some key variable about the person's past medical history from, you know, when they were an infant, for example, that might preclude them from being able to be included or excluded from the study. And so that it's a different set of questions. Oftentimes, inclusion-exclusion criteria are very closely linked to exposure and outcomes, but not always, particularly if you're looking for something that might have been an inclusion or exclusion criteria that happened in a really different setting besides the setting where your data for exposure and outcomes are coming from. Is the exposure duration long enough, or the follow-up duration long enough, right? So maybe you can detect an exposure happened, but you don't know how long that exposure occurred, and that's a key variable in your analysis. Or you know that it occurred at least a year, but you really want to see if people had 2 years of exposure. So thinking about the granularity both in terms of the actual data element that you can get and also the length of time for which you can get that data element. Is there enough historical data to determine baseline covariates? So this really gets at ideas where you're doing maybe more of a pre-post design. We'll talk about that a little bit more when we talk about different types of study designs. But if you're trying to look at something that happened in era 1 and compare it to something that happened in era 2, you need to make sure that you have the same amount, enough historical data in era 1 to be able to figure out, well, what's the baseline level for those covariates so that I can then look and see how they might have changed in era 2. Another thing that comes up in a lot of institutions is whether all the relevant care settings have the right data available. So you might work in a health system where there's 12 different sites, and 2 or 3 are like the main hospitals, and other sites are more ancillary or just partial services, and maybe people don't follow quite the same protocols there, or they don't have the same patient populations, or they don't have all of the different exposures available, only a subset. And so trying to think through, when you're getting data, especially health system data, are all the components of the health system able to contribute all the pieces of data that you need? And then also this idea of, are there data for exposures from other sources? So this is the idea about adequate data for inclusion or exclusion, but can also relate to covariates. So for example, a really common one is death data, right? If you're using EMR data, like I know our EMR is not linked to deaths outside of our hospital setting. So if you have death as a really key variable for somebody in your study as an outcome, you're only going to know partial outcomes because you don't have the death data from, say, the county or the state. Or another example might be environmental data. So if you're looking at asthma and the effects of medication, maybe you really need to also factor in the particulate matter in the air over time, or in response to forest fires or something like that. Can you detect differences in demographics, or I wouldn't even say that necessarily demographics, but any type of characteristics that are defining different populations, and can those differences be addressed? So race was an example that I gave before, that often is missing in certain data sets, or is misclassified or classified based on the person inputting the data rather than the actual patient themselves. And so can you actually identify that and feel confident about those data so that you can look at comparisons between groups? And then of course your sample size, right? Once you get down to all of the other questions being answered, do you end up with enough people to actually fulfill the study population and be enough people in your population to actually be able to do your analysis? All right, so we're going to just quickly go through a couple slides on study designs, and then we're going to have some discussion at the end. Any questions? I want to just take a moment of pause to see if anybody has any questions or comments about anything that we've talked about so far. Okay, we'll keep going. All right, so we talked about some of these already.
Mandy, this is Chris. I'm sorry, can I ask you a quick question? So, yeah. This great presentation. I love it. Where do you think big data and this whole area of big data fits in? Is that just a different type of observational study, or is it really something different?
I think it has a lot of overlap with observational studies, in that some of the issues or potential disadvantages of observational studies can be potentially addressed by big data because it's so big, or because it's so granular, or both. But I also think that, the way I understand big data is that I'm thinking now like, Facebook data or like cell phone data or something like that. It might not be the right type of data. So I guess I would say it's a subset of observational studies, but there's probably a lot of what we would call big data that's actually not even really necessarily that useful for observational research. I don't know, what do you think?
Yeah, no, I think that's a great answer. I was thinking as well as about artificial intelligence and integrating that into the research sphere. Not just algorithms, but algorithms that learn over time, because there's a lot of talk about, and they're like conducting repetitive experiments, but now the human observer is no longer involved. The algorithm is learning itself, and where that fits in this construct of observational research is it's a little unclear to me. I kind of think you're right. It's sort of like there's a lot of similarities, but as you begin to talk about AI and AI algorithms, it may be moving into a sort of a different space all by itself.
Yeah, it almost seems like a whole new methodologic area. And, maybe in several years from now, we'll be able to say like, oh, if we use this AI tool, then we can actually get rid of even more of the biases in observational studies. But to me, I feel like that's such a nascent field right now that we don't really understand it very well or all of its applications. So I guess I hope it's going to be a potential solution to some of the problems with observational studies, but I think to me there's not enough data out there yet to be able to conclude much about that.
Yeah, great, thank you.
Okay, anybody else? Okay, we'll keep going. All right, so in terms of study designs, we talked about some of these already. A cohort study where you follow a group of people over time to see their outcomes, and case control where you work backwards. You start with cases, you select controls, and then you look at exposure. But there's some other ones here that I thought were kind of interesting that I guess I've sort of heard of, but maybe hadn't really thought through. So one is this case crossover study, which is where you start with only the cases and there's variable exposure time. So it's almost like a pre-post, but it's like the cases serve as their own controls in a way. And so it works really well from what I can understand of reading these articles that for things that are transient exposures where the exposure time is known and where you expect that you'll be able to detect a signal based on that amount of exposure time, especially if you have sort of expectation that your outcome variable is going to happen in relatively short time beyond when the exposure has ended. And an important category though is that the changes in your exposure shouldn't be triggered by health events. So a classic example that they give is about like policy changes, right? So wearing masks during COVID. Nobody was supposed to wear a mask, then everybody was supposed to wear a mask, and now less people are wearing masks. And so those are wearing a mask or not wearing a mask. I mean, obviously there's individual decision making there, but there's also sort of this governmental oversight or recommendation that's happening. And so sort of more policy related things where it's not necessarily a trigger from a health event on an individual level, but more broadly. Then there's the case time controlled, which is the same as the case crossover study, but it includes a control group that didn't get the exposure. So what this does is it eliminates the assumption that there was nothing else that was happening over time beyond the thing that you are calling your exposure. So for example, in the case of COVID, let's just say, there wasn't suddenly a new treatment for COVID infection or a new prophylactic treatment that prevented COVID infection that only some people got. So it helps to be able to potentially statisticalize away some of those unmeasured confounders. And then there's the self-controlled case series, which is a comparison of effects during treated and untreated time. I'm a little unclear how that's different from the case crossover, other than I think people can go back and forth between the two different states of being treated or untreated multiple times, as opposed to case crossover, where it's kind of just once you're crossed over, then you're in the other group. Some other ones are natural experiment studies. Those are particularly good for like population level interventions that happen and usually require longitudinal data and are most helpful if there can be multiple sites of replication. So one that's pertinent to my field is vaccination and state policies regarding vaccine exemptions. So there's a couple states that now no longer allow non-medical exemptions, and people have started to study the couple states in which that has become a new rule recently. And there's some conclusions that are being made from that, but if we had like half the states that had that same policy, I think those conclusions could be a lot more robust and potentially more valid. Then there are pre-post studies where we're talking about different eras. And so I think of this as really in the realm of QI, where we're having like maybe looking at the trend of something happening in an initial period, and then we do something, and then we're looking at the trend or the level of something that happens in another period. And then studies where you have planned variation. And some of these start to get into randomized trials, but from my reading through this, it seems like sometimes these aren't randomized, and so there are maybe a role for some of these more intricate study designs in observational studies. So like a stepped wedge, right? An example of a stepped wedge where you had an RCT is that you controlled for each of the groups and they were randomly assigned to when they were going to start their intervention, and over time you go from 0 of your groups having the intervention to all of your groups having the intervention. So you kind of end up with 2 triangles in terms of exposure time. But you could also imagine a step wedge in an observational study where you're not having that really tightly controlled randomization. So an example might be a QI project that happens at one site and then another site and then another site and then another site, and you're looking to see is the same type of effect from that intervention happening at all 4 of the sites that started at a different time. A variation on that is a delayed start where everybody's going to get the intervention, half of them get it right away and half of them get it a little bit later, and maybe the determination of which half you go in is not randomized, but based on readiness of your institution to make that change. And then factorial designs can often be part of a randomized controlled trial if you're assigning randomly which of the 2x2 square that you're going to. But sometimes factorial designs are part of just natural things that happen, like a person with disease X got either A or B or A and B together or A and C together. And so you're able to do some kind of factorial analysis looking at the individual effect of treatment A and also the combined effect of treatment A and B. That was a little bit maybe theoretical. Hopefully that made sense to people. And then when we're thinking about analytic methods, really the main thing to consider is that there are 2 main sources of bias in observational studies. And we've talked about these already, but they're sort of distilled down into easily digestible cognitive chunks is that the experimental groups don't have the same likelihood of receiving the treatment or the exposure. So, sicker patients get a different type of care than less sick patients, for example. Or you have confounding by unmeasured variables. Site A has a different patient population than site B, and you don't exactly know in what way it's different, so you can't necessarily compare the 2. So these are several methods. This is where I hope nobody asks me any questions because I don't know a whole lot about any of these. They make sense to me, but I couldn't explain them to you beyond kind of my very top level understanding. So the first one is regression discontinuity. And this is basically where you believe that you're going to reach a certain threshold after an intervention. So an example might be something where you get to an O2 sat of 100% or above 95%. So you can't go much beyond 100%, so there's only a threshold and you don't expect there to be a linear increase, but maybe you could find something where there's something that happens and you get to one level and then you reach a threshold and you say you've become a quote unquote success. Another one that I'm much more familiar with is interrupted time series. This happens a lot in QI work where you're looking at maybe the slope of a line of something that happened in a pre-intervention era and the slope of the line or the actual mean of that line and something that happened in a post intervention area. And when you're looking at the slopes, this is also called segmented linear regression. So you're looking at basically 2 different linear regressions corresponding to 2 different time periods and looking to see are their slopes different between the 2 time periods. And there's statistical ways to be able to do that. The next is called the instrumental variables approach. I had never heard of it, so I actually wrote down the definition here because I didn't think I could explain it very well. But basically, it's like where you identify these special variables that you think are really likely to affect the treatment that a person gets, but are unrelated to the outcomes except through the treatment. So an example that they gave is a distance from a healthcare facility, right? So if you live far away from an academic center, you may be much less likely to get a really cutting edge type of intervention as as opposed to if you live really close to an academic center. And so that is really related to the treatment that they are receiving, but aren't necessarily directly related to their outcome per se. And then propensity score analysis, which is also one that I'm more familiar with, which is basically where you're trying to simulate a randomized controlled trial by equating two groups using a single composite variable that reflects associations with treatment. So a classic example of this is when you're trying to factor in different levels of patient severity across different types of hospitals and trying to understand whether or not, you know, treatment A was better than treatment B in terms of patient outcomes. Well, if hospitals that mainly got treatment B are reflective of hospitals that have a lot less sick patients, is there some way that you can equate the sickness of the patients across all the hospitals to make them more uniform so that you can look in isolation at the effect of the treatment? Okay, so I thought we could spend just a couple minutes. Let's see what time we're at here. Okay, we've only got about 10 minutes left. So let's spend a couple minutes trying to think of some case examples where observational studies and RCTs maybe are complementary. So the one that I thought of most likely was rotavirus vaccines. So several decades ago, there was a new rotavirus vaccine that was developed for infants. It underwent rigorous randomized controlled testing over tens of thousands of different people, and the vaccine was thought to be safe and effective, and so it got rolled out into the public health domain. And then something called the Vaccine Safety Data Link, which is an observational study tool that encompasses and captures data on millions and billions of people, started to show a signal where the rotavirus vaccine seemed to be associated with an increased rate of intussusception among infants compared to baseline rates. And then they were able to do more rigorous sort of case control, a second level of observational studies where they concluded that that actually probably was the case, and so the vaccine was pulled off the market. One that was mentioned in some of these papers was actually one, Chris, that you were involved in about extension of biological medications for Crohn's in adults into pediatric populations. And they were talking about how there was RCTs done in Crohn's adults, looking at the variation or the effectiveness in different Crohn's disease medications, but there wasn't trials done in pediatrics. And so it sounded like there was a study that you were involved in with Improved Care Now that looked at differences in outcomes related to different choices of medications in pediatric populations that wasn't an RCT, but supported the RCT data from adults. People want to talk about others that they might have, other examples, or Chris, if you want to talk about your example.
I can talk briefly about that. We published that in Pediatrics, and so what we did is we knew that there was a fairly expensive randomized trial called SONIC, published in the New England Journal of Medicine. I think it was like $15 million, 500 patients. You know, RCTs. If you're doing some of these RCTs and it costs $10,000 per enrolled patient, you think you're actually saving money. I mean, they can be very, very costly to find patients who meet certain criteria. The SONIC trial compared people who receive biologics versus standard of care, which is basically just thiopurines, and it came up with an effect size at 6 months of about 1.68. So that's an effect size computed as an adjusted odds ratio. Actually, it was a rate ratio, it was a Poisson regression for a steroid-free remission. So people were not on steroids and they started out pretty sick. And the question is, did they go into remission, yes or no? And is there a difference between the two groups, those who got biologics versus those who didn't? They were randomized to that, and so the effect size was 1.68. We replicated the methodology, we replicated the selection criteria, but adapted it for kids. We used some observational statistical methods that were kind of fancy. I like to statisticalize. We statisticalized the data, but we basically what we called it was pseudo trials. We created what looked like 6-month trials, but we used data that was collected over a large period of time. And our effect size, same outcome, same follow-up period, was 1.7, very, very similar. And so the FDA actually now is very interested in, because there'll never be enough time or money to do all the trials that are needed for kids, in trying to use this kind of approach to extend evidence from adults to kids. Where you get the same answer, then you feel comfortable. When you get different answers, that's when the discomfort sets in. So I think this is a wide open area for exploration, but it's certainly something that's highly relevant to pediatrics.
Thanks. I couldn't say that I completely understood what you did, but it sounded pretty fancy. It was pretty cool. All right, so the last part of this is just a discussion, and Jeannie, you can tell us when we need to transition to the WIP. These are just some questions that I thought might be interesting to talk about as a group, about what kinds of questions you've seen in your own practice where there might be a benefit from an observational study, or issues that people who have done or are doing observational studies have run into regarding either the methods that they're trying to do or interpreting the data from what they thought was a great study, and then things turn out to be a little bit more confusing than maybe what they initially thought. Or examples of where conclusions were made from observational studies, but really an RCT is needed to be done instead. And I'll just chime in for that one. You know, I'm sure Chris has mentioned the HERO study and the HERO registry. There's a lot of data that's come out recently about hydroxychloroquine and heart arrhythmias. And some of that has been from RCTs, but the two studies that were recently retracted were observational studies, where there was a suggestion of a signal, and then there was some questions about the validity of the data. So I think that's a really great example of where conclusions, at least in the media, was made by observational studies, but really an RCT is needed to be able to address and overcome the barriers of the observational studies that were done. And the issues, the barriers there was about confounding factors in the patients who were getting hydroxychloroquine. A lot of them were very, very sick and also getting other kinds of medications. And so it was very hard to sort out whether the effect was hydroxychloroquine related or other things. So I'll leave these questions up here. If anybody wants to chime in, or Jeannie, if we need to move on, that's fine too. I'll let you tell us when we need to transition.
No, I think we have some time, so we should open up the floor.
Okay. Anybody want to comment about any of these? I'm sure people have experienced the middle bullet.
For me, in pediatric cardiac critical care, like thinking about the best way to approach certain neonates with certain lesions comes up often. We have the PC4 database, but we do struggle with the granularity of the data. And so we find ourselves often limited to these descriptive studies that actually don't help us know what to do with the individual patient in front of us. One of the hot button topics right now is PDA stent versus neonatal surgical repair for some of the ductus dependent lesions. But we're finding that our PC4 database doesn't really help us answer that question well enough to really know what to do with the individual patient in front of us. And then if we just do this as a single center, we struggle with having enough patients to make those conclusions. So figuring out a way to make our national databases where we are collaborating robust enough to answer these next questions beyond descriptive studies is really our goal and our challenge.
I've heard similar challenges for other people that study relatively rare diseases where there's, you know, multi-site collaboration and registries being used. Is it's like we don't have the right data for our question that we really want to answer. I think that's a very astute observation.
I think with those, it's a balance of too much information and too little information. And so oftentimes I think it feels like you're having to kind of scale back to figure out what to collect so that it's not such a burden on centers, but then at the same time, then you don't have what you need to actually answer the questions that you want. So I think that's or there's a lot of missing data because, you know, you're asking too much and then sites sort of enter what they want to enter, it seems like, or what is easiest to enter.
Yep, for sure.
I think one broader issue with observational research that we haven't touched on is sometimes observing or assessing in and of itself can change a behavior. And so we think about, particularly like when it comes to psychosocial risk screening or assessing mental health concerns, we know that asking questions about psychosocial risk and mental health can impact those very symptoms. And so thinking about, how are the assessments you're using potentially related to changes down the line has been something that we think about a lot in at least the mental health domain.
Yeah, that's a really good point. And earlier there was a bullet about maybe there's some minimization of bias if you're collecting those data for non-research purposes. I mean, I agree, like anytime you ask about a mental health thing, you have a potential to introduce bias just by the fact that you're talking about it. But it makes you wonder, like, well, if you had to choose between, let's say you had a really robust data set of some of these mental health outcomes or questionnaires that were collected in clinical care versus questionnaires that were collected as part of a research study where a person was coming in for a research visit and saying, now you're going to fill out these 7 mental health questionnaires to tell me all about your mental health. I don't know, it just makes you wonder. I mean, there's bias in anything, but it can go, I guess it could go either way. It's just something to think about.
Mandy, I just had a question for you, or Chris as well. Just when we think about applying observational study methodology to some of these larger data sources, EHR-related data, is there something, or is there talk about developing guidelines the same way that there may be the consult of the STRO checklists or Squire guidelines for QI? Is there sort of work that's currently taking place to try and sort of establish best practices about how you look into data quality issues, how you, the bare minimum things that you need to think about as you're thinking through these research questions and applying some of those methodologies to larger data sources?
That's a really good question. I'm going to punt that one to Chris because I think he would know the answer better than I.
There is not, interestingly, and PedsNet, actually, the data science group across PedsNet is very interested in developing those. So kind of like the guidelines for reporting trials, we fill out consort checklists. And if you go to Equator, there's checklists for all kinds of different methodological studies. There are checklists for observational studies, et cetera. But when it comes to using EHR data, there's 2 types of data quality. We talked about this briefly in the informatics unit. One is syntactic, which is it there? Is the data missing? Basic missingness, which is, really within the statistical frame. Data can be missing at random or missing not at random. Then there is semantic data quality, which refers to, does the data make sense? And the criteria for what level of reporting should be done for semantic data quality for electronic health records is just not present. So we actually have a proposal. It didn't get funded the first time around. Charlie Bailey is the lead to develop guidelines for semantic data quality reporting. I see that happening over the next several years. And what we should start seeing in papers is, rather than table 1 is your study population characteristics, table 1 will be the assessment of data quality. But what goes in that still needs to be determined.
Interesting.
I think with that, Mandy, if it's okay, we'll pass it off to Amy. Yeah, thank you so much for your talk. It was really great, and I love how applied it was. I think everybody probably agrees that how great your sharing was.
I'm sure they all agree.
We're calling you back for sure. All right, so with that, I'm going to just switch the presenter role and give it to Amy.
Okay.
Good enough? Amy, did you get the invite?
I think so. Can you see my PowerPoint slides?
Oh, yeah, I do. Do others see it? Okay.
Okay. Yeah, this is very weird. I've never done presenter mode in go-to meeting, so it looks very different. So feel free to jump in and ask questions along the way, since similar to Dr. Dempsey, I cannot see people's faces. So hopefully you all can jump in and ask questions along the way. So I'm really excited to be able to share some of my work on engaging stakeholders to improve hydroxyurea uptake amongst youth with sickle cell disease here at Nemours. So just to be brief, we know that hydroxyurea is really gold standard care for youth with sickle cell disease. A lot of data to suggest that it's safe and efficacious for reducing pain and acute chest, reducing hospitalizations, and improving growth, survival, health-related quality of life. And yet, despite all this good data to suggest that it's a really important treatment that works, we know that many youth with sickle cell disease, unfortunately, don't receive the benefits of hydroxyurea. So some of the most recent available data suggests that anywhere from about 1/3 to 2/3 of kids with clinically severe sickle cell disease receive hydroxyurea. And there's significant variability across both providers as well as institutions in terms of how many kids with sickle cell disease are prescribed hydroxyurea. So we, last year in 2019, conducted a bit of a self-study to look at our rates of hydroxyurea uptake in kids with sickle cell disease at Nemours. And overall, we found about just over half, about 52% or so of kids with sickle cell disease receive at least one prescription in a year. So we use a pretty low threshold for understanding who even gets exposed to hydroxyurea. But we wanted to look at the patterns over time and across age groups as well. So as you can see, we looked at four years from October 2014 through September 2018, and we picked this time period because there was a clinical practice change announced in September 2014. So NHLBI, given additional data that was accumulated, it used to be that only kids with clinically severe disease were offered hydroxyurea, but they kind of switched their position in 2014 and said really all kids with sickle cell disease who have the more clinically severe genotypes, even if they haven't presented with disease manifestations yet, should be offered hydroxyurea as young as 9 months of age. And so that was a pretty significant guideline change in 2014. So that's why we've selected that as our start date. And as you can see, for the little kiddos, for the 0 to 5, we see a nice increase in terms of the percentage of kids with SS and S beta 0 type, which are the more severe types of sickle cell disease, from 20% in year 1 doubled to 40% of kids with those genotypes on hydroxyurea here at Nemours, but still lots of room for improvement. Whereas you see kind of in the preteen and teenage group, it's a little bit more of a stable trend across the years, not much change from maybe mid 40s to low 50s. And then in the young adult population who are still receiving care at Nemours prior to transitioning, you see kind of a nice increase from 47 to close to 60% before transitioning to adult care. So certainly we see some improvements, particularly in the younger kids, but a lot of room for improvement in terms of getting more kids with sickle cell disease on hydroxyurea. So we wanted to understand those data better. And so we started by talking to patients and caregivers. We conducted qualitative interviews to really understand what were the factors that were important in their decision making around hydroxyurea. So we purposefully sampled a diverse group of patients and caregivers, both in terms of demographics, but also in terms of their exposure to hydroxyurea. So some patients were on it currently, some had been on it previously but discontinued, and some had never been on hydroxyurea. And we interviewed both they and their caregivers about what were the things that were important when making those decisions to either start or restart or continue or discontinue hydroxyurea. So these were the 5 most commonly discussed barriers that families mentioned. So the first was fears regarding chemotherapy. So hydroxyurea is a chemotherapeutic agent, was initially developed in oncology and in HIV treatment, and then later used in sickle cell disease. So there was a lot of concerns amongst families about why chemotherapy would be used for sickle cell disease. So for example, this mom talks about just the thought of chemotherapy and all the associations that the lay public tends to have about chemo, about weight loss, hair loss, infections, not being able to get out of bed, just kind of the idea of a chemotherapy patient. Even though we don't see those side effects in kids with sickle cell disease who are on hydroxyurea because it's used at a much lower dose, that's still something that patients and families really feel very fearful about. Concerns about side effects above and beyond those that are associated with chemotherapy also was something that was frequently discussed. The patient and family's own perception of how severe their child's disease is was a very salient factor. So, for example, this female talks about how she does have pain crises, but she doesn't really feel like she has enough to warrant treatment with hydroxyurea. So there's a sense that hydroxyurea is really a last resort, or not a necessary treatment, but one that you resort to if you're having many complications rather than preventive treatment. And then there were, concerns about long-term and unknown risks. We have about 4 decades of research on hydroxyurea in pediatric sickle cell disease, but parents do wonder about long-term risks that are just not yet documented. So this mom talks a little bit about potential kidney or liver or other organ damage related to hydroxyurea. So those were some of the things that families told us were the most important barriers when deciding around whether to initiate hydroxyurea. These were the most frequently reported facilitators, or the things that factors that encouraged or helped make the decision to start hydroxyurea. So having a positive, trusting relationship with their sickle cell disease provider was something that almost universally families talked about. So this, I won't read the whole quote, but this female talks about how she really feels like her providers care about her as a whole person, how they are not just interested in pushing medication, how they really care about what's going on in her life outside of her disease, and so that helped her make the decision. Obviously, recognizing or perceiving that hydroxyurea works or that it's efficacious was something that families talked about being a positive motivator. Families where they have caregiving supports available, so where it's not a single parent household, where there are other adults who are able to help manage the increased clinic visits or the additional lab work that needs to be done to be on hydroxyurea. Talked about how that was something that helped them make the decision that it could be feasible for family if there were other caregiving supports that were available. Similarly, and earlier I said that families where they perceive that the disease is not severe, that's a barrier. The opposite is also true. If they perceive that their sickle cell disease is really severe or problematic, causing lots of complications, that is something that motivates families to start hydroxyurea. So this mom talks about how not only was her son in the hospital a lot, but she also unfortunately lost her job because she took too much time off of work due to his hospitalizations, and so that was really the kind of straw that broke the camel's back, and why she decided to start hydroxyurea for him. And then understanding kind of the mechanisms of action, so not just that hydroxyurea works, but how does it work? How does it impact red blood cell functioning? Was something that a lot of families who are on hydroxyurea discussed as being important for why they chose to start the treatment. So this is just a few key takeaway points that we learned from talking to patients and families. One was that even families who decided that they didn't want their child to be on hydroxyurea suggest that all families really should receive education, that education needs to be provided earlier than it currently is being provided, and that it needs to be more comprehensive. It needs to cover more topics than what they currently are being offered. that they want education in multiple modalities, so not just conversations with providers, but also informational resources. And universally, families and patients told us that they wanted to hear from other families who had direct experience with hydroxyurea, not just talk to their providers or read research. They really wanted to know more about what it was like for other families who had experience with this treatment. And that they wanted help with identifying and problem solving the barriers that often make it difficult to adhere to treatment. So we also talked to all of our healthcare providers. Our team here in Delaware Valley includes 3 physicians, 3 APNs, 1 RN, a social worker, and a psychologist. Just quickly, even though families tended to focus mostly on barriers and facilitators at the level of the patient and the family, providers talked about those barriers, but they also talked about things at the level of the provider and the organization. As you can see, we have kind of a nice stepwise. They perceive the most barriers at the family level, and then followed by the provider and the organization. Then you see kind of the opposite trend in terms of the number of facilitators discussed. In terms of what providers told us, in terms of most frequent barriers, they talked a lot about patients and families who have history of poor adherence and how difficult it is to make decisions around offering hydroxyurea when you know a family is going to have difficulty coming for labs or taking a medicine every single day, that it's different providers have different thresholds for whether or not they will offer the treatment if a family has history of poor adherence. Another salient barrier that providers discussed was kind of this variability in offering it versus really advocating for the treatment. So this provider talks a little bit about how for some patients, they're really adamant about wanting the family to start, whereas for others who might not be having that many complications, where it's kind of more offered as here's an available treatment, they're not really advocating strongly for it. And then they also talked about patient and family cognitive limitations and language barriers being an important piece. So kind of the difficulties around using language translation resources and how it takes longer to do those education visits, as well as feeling reluctant to start hydroxyurea with a family that doesn't speak English because worrying about misunderstanding dosing instructions and things like that, as well as even for English-speaking families, intellectual or reading or cognitive challenges that might make it difficult for a family to understand hydroxyurea and why this treatment might be beneficial. And then similar to families, I talked about side effects and fears around chemotherapy. So I'm going to go quickly through this slide because I recognize I'm running out of time. These are just some of the frequently reported facilitators, so things like the providers working together and collaborating, communicating clearly, when they strongly recommend or advocate for hydroxyurea, when the provider themselves perceives that the patient's sickle cell disease is very severe, when the provider takes the time to identify and problem solve what the family's barriers are to starting hydroxyurea. So rather than just saying, okay, we'll talk about it again next time when the family doesn't agree, really taking the time to understand what the barriers are. As well as a culture, a learning climate at Nemours that is very receptive to innovations in care and that views this topic as being a high priority. But those were some of the really key facilitators. So I'll skip those quotes. So all of that work that we did over the past year really informed the design of my PEDSENT K-12 study, which I'm conducting now, which aims to characterize the implementation process at sickle cell disease centers nationally with low and high hydroxyurea uptake. So to do that, we built a query within the PEDSENT data network. So we're waiting for that to be reviewed and for that to be executed. But essentially, we're going to be looking at kind of doing the same thing that we did at Nemours, but looking at all PEDSENT sites. So looking at those who are eligible for hydroxyurea and how many are actually getting it. For PEDSENT hospitals in the top and bottom quartiles, we'll recruit both sickle cell clinicians as well as center leaders into Yammer, which is an online crowdsourcing platform, essentially like a closed Facebook group is kind of how I view it. So we'll be recruiting them to participate in an online crowdsourcing study where we'll be able to ask them questions about implementation processes that might contribute to high or low uptake in their settings, to essentially learn from what's working well and what's not working well at other centers, and how can we adapt those strategies for our context. And we chose crowdsourcing because it essentially provides the benefits of a focus group, but it's asynchronous, so we can ask questions and people can respond and to our questions as well as other responses, but they don't have to all be present the same day or time. So we felt like that would be beneficial for recruiting, you know, a diverse group of providers and leaders. And then the second aim of the study is really to take everything we've learned from our pilot work, from theory, from research, our prior research, and from what we learned from the crowdsourcing to develop a menu of strategies to improve hydroxyurea uptake here at Nemours. So we're already working on some things like VR-delivered hydroxyurea education, on adapting shared decision-making tools, but we hope to add to this list of strategies through our crowdsourcing work. So here's just a snapshot of kind of the strategies that we've already begun to brainstorm with our clinician stakeholders, but as I mentioned, these will be further refined and informed, and we'll decide kind of which bundles of strategies to begin trialing based on some of that crowdsourcing work that we're doing shortly. So I'll just end by acknowledging that it takes a village to do this work. So I really appreciate all of my mentors, collaborators, funding sources, and I'm happy to take any questions. And hopefully I can figure out how to see everybody again.
So Melissa, sorry, Amy. Melissa, I'll defer as your advisor. Amy, Chris, can you sort of project if you were to implement the best practices at some of these PedsNet sites, and also what you've learned from all of the work that you've done on the various stakeholders involved in the decision-making process? What's the rate you could get to? How high can you get with hydroxyurea uptake?
I think it depends on what you define as uptake. So if you, I mean, we've been really focused on initiation, but we obviously know there's a lot of adherence barriers as well. But I think given anecdotal evidence from colleagues at other institutions, I would say the highest rates I've heard of are hovering around like 75, 80%, at least receive prescriptions, you know, and then, you know, whether or not they're taking them, we would assume that that percentage would be lower. But I think talking to our clinician stakeholders, 80% would be fantastic as a goal.
Yeah, so 80% target. And can you estimate the number of events that would be prevented? I'm trying to think about how you make the case for this work with payers and health systems. Like, what's the value of it? You know, there's a really interesting model, but there's also potentially an economic value proposition that you can make as you move forward with it.
Yeah, I think that's an interesting way to look at it. I mean, we could look back at the big trials that were done to see the odds ratios in terms of number of acute chest and pain crises and other adverse events prevented.
Right.
To estimate, you know, if we did reach 80%, what that would look like at the healthcare system level. But I don't have the numbers in front of me.
No, not expected. But you could use the information from those prior studies, and then you could use health plan data or PedsNet data to figure out like lengths of stay, and you could get, you know, a per diem for hospitals. I mean, I think you could actually compute a cost savings for this, and that would be part of the equation. And then there's going to be a certain amount of cost associated with implementing the program, and there may be a pretty strong value proposition here in terms of number of dollars saved with implementation, which you can make to both the health systems and to payers.
Yeah, thanks. I appreciate that comment. I think I need to learn a lot more about cost effectiveness analyses to do that work, but I think it would be worthwhile.
Any final questions for Amy?
I'll put in a shameless plug. We love that Amy is doing this, and it has been a joy to work with her, and I think our patients are going to see the benefit. So keep going.
Karina is one of my collaborators, so she's a little biased in that comment, but
oh, I'm totally biased, but it's all accurate, I promise.
This is another example, Amanda, of what I was thinking about with observation changing behavior, because when we started this work, we noticed that the enthusiasm, I mean, the sickle cell team already felt like hydroxyurea uptake was an important issue, but once we started really focusing on improvement strategies, I don't know, Corinne, if you agree with this, but the level of enthusiasm and effort directed towards like, oh, I'm going to make sure I talk to that family again, even though they've told me no 8 times already, has gone up. And so I think even just us observing this care gap has made some changes in behavior.
Yeah, it's like assessment.
I totally agree.
Mm-hmm. Yeah, we were auditing and feedback without intending to, I think. Yeah. We meant to just audit.
All right, thanks everyone. We've hit 1:30, so just thank you again to Mandy and Amy for putting together a great session, and everyone for joining. I'll be following up with an email with some of the items that I mentioned at the beginning, and have a great day, everyone. Thank you.
Bye, everyone.